Yes.
Please. So
Okay.
I would like to first of all thank Dr. Khaitan for the kind words and Dr. Virmani for the kind invitation, and to the organizers of the Cardio-Diabetic Society. It's really a great honor to be able to share some of the experience about the ventricular tachycardia management. I mean, I know most of the people are already aware. I'm more of a person of atrial fibrillation, and my expertise has been in that. However, uh, only when I was in Bihar, in fact, that was the time when I was able to help Abbott USA to get the approval for the world's first epicardial VT ablation catheter, in fact. So what matters is the right attitude and knowledge rather than just the location. So with that, let's try to go to the ventricular tachycardia, our topic. We all are aware, I think, how to diagnose the ventricular tachycardia, what are the algorithms which we all follow. I'll try to give um, personal experience as well. So for example, about the types as well, how do we differentiate the uh, ventricular tachycardia on the basis of sustained or non-sustained? Similarly, pulseless VT, or is it stable, unstable, monomorphic, polymorphic, or idiopathic or structural as well. So I'll give you one example of case over here, which we came out recently, I would say, during the COVID-19 pandemic. Uh, Dr. Lohani already said what are the problems. So what happens is, even for us to be able to perform procedures, we all have to be there in the full PPE suit, and it's not easy, being in the EP lab, for example, standing there for like 5 or 6 hours. So this was an example, 61-year-old gentleman, known case of non-ischemic cardiomyopathy, whose ejection fraction was already 10 to 15%. What happens is he had already underwent dual chamber ICD implantation as well. He was receiving multiple shocks. So what happens is we have a pretty active cardiac transplantation team as well over here, but he was refused for that. The reason being he was continuing to smoke. So we got a call. This gentleman had already received 11 shocks for recurrent VT. He was already on the up-titrated dosage of most of the best antiarrhythmic medications, which we had, including amiodarone, bisoprolol, mexiletine. So earlier, he was already attempted for VT ablation. However, he landed up in a complication as well. Then, as I said, heart transplanter was not considered for him because he was a unsuitable heavy smoker. So what do you think? What shall we do with this gentleman? Shall we just leave him to die? As I said he's just in his 60s. So a lot of time is there for him in his life. So with this clinical scenario, I will leave and I will go to the theoretical aspect of it. Of course not, we are not going to leave him. So in the meantime, let's try to go through the things. How do we diagnose VT? I think everyone knows about the different algorithms, the Brugada's criteria, we must do, if we come across a case of VT, always I would suggest is try to get a 24-hour Holter, a 2D echo as well, try to get the routine investigations, and also the electrolytes, because that is the time when we can come across a lot of reversible causes. Reversible causes, because what happens is sometimes it can be drug induced, sometimes it can be electrolyte induced, or sometimes we can also come across the other problems, which can be really the etiology for the ventricular tachycardia. One of the things which we all get scared is, what if the VT is unstable? In that, still the algorithm still holds true, the old one, in which we just shock, okay, in the ascending order. Even after that, if it is still not able to convert, start on amiodarone. And yes, even for the pulseless VT as well, still DC cardioversion is still the rule of the thumb. What if the patient is stable? If it is a monomorphic ventricular tachycardia, we should again try to see for, if the left ventricular function is good, then intravenous amiodarone, procainamide, or even lidocaine can be considered, considering the comorbid conditions. And if the LV function is impaired, we are limited with the choices. Like the lidocaine or amiodarone still can be preferred, especially to the procainamide, even when we are thinking of pharmacological conversion, because what happens is the procainamide can exacerbate the heart failure as well and can further worsen. So one of the things I always share, especially in arrhythmia management, is know your drug, know the drug's contraindication. So for example, even drugs like ibutylite, if we can use it for a patient of AVRT or the paroxysm of AF, we can use it. But if we know the contraindications, then we can also prevent the complications as well. Similarly, as I had said, it is if the patient is again in stable VT, some of the options which I had already said it was about lidocaine. Lidocaine is again a class 2B drug, which we all have to give IV bolus at dosage of 0.5 to 0.75 milligrams per minute, or even IV sotalol is another suitable alternative. This is a wonderful summary of the management of the sustained monomorphic VT. Another key thing, which I think we all are very much aware about the polymorphic VT, it can typically terminate, especially on its own. However, it has a tendency to recur. And after returning to sinus rhythm ECG, ECG must be analyzed. What happens is the analysis of the ECG is key to its origin. Okay. And on the basis of origin, we can predict which drug can be pretty helpful to the patient as well. And even in the stable VT as well, sometimes we do come across if the QT is prolonged. So if the QT is prolonged, intravenous magnesium sulfate, which is a class 2B agent, can be pretty helpful. So for example, 1 to 2 grams of magnesium sulfate diluted in 5% dextrose. Similarly, even phenytoin, which can be given in the normal saline. And for the long-term management, there are already a lot of clinical studies which has been done, which has shown the role of flecainide, morsizumab, or the other drugs like dofetilide, in fact. So the almost always is managed by medication or even ablation. Amiodarone in combination with beta blockers can be pretty useful for patients with LV systolic dysfunction because of the prior myocardial infarction, and even the patients with heart failure are treated with beta blockers, including carvedilol, bisoprolol, or metoprolol, or even the aldosterone antagonists. One of the other drugs, what I would like to really highlight, the ANI inhibitors, which are used in heart failure, has been recently shown to also suppress the ventricular tachycardia as well. So one of the things which everyone about VT storm. So if there are more than 2 episodes in 24 hours, or there's repeated VT episodes requiring external cardioversion, defibrillation, ICD shocks, this is what is the classical presentation of VT storm. So in that, if it is secondary to Brugada syndrome, IV quinidine or IV isoproterenol also has great role. In fact, the Purkinje fiber ablation has recently been shown to be having an impactful role for the VT storm patients. I'm pretty confident most of the audience members who all are here, they all are using smartphones, isn't it? So in the time when our smartphones were becoming smarter, pacemakers were becoming smaller and better. Similarly, the ECG tools has been becoming better. He is Dr. Eindhoven, where I did my my clinical training from Maastricht, which is just at 1 hour distance. So this is the world's first ECG, which was being done by Eindhoven. So now things have become so much improved, like you can even record the ECG not just using smartphones, but even watches as well. So now you can even visualize the ECGs by using the 3D anatomical mapping. In fact, not just invasively, but also non-invasively. And the maps are becoming high definition mapping is available. And in fact, we are also able to see the smaller micro reentry circuits. That's the reason why we are able to give them better quality of life and also better success rate as well. Now coming to our case, what shall we do? What shall we do about that gentleman? Shall we leave him to die? No. So what happens is whenever the ventricular tachycardia was happening, his blood pressure always used to drop down to by like 50 by 40 almost. So the procedure was being planned at Blackpool University Hospital under the leadership of Dr. Khalid Abuzgia. I will show the pictures as well. So this is what is called as the impella. Impella is a bridge to LVAD or even cardiac transplant as well. So the beauty of this is it takes blood from here and it takes out the blood in the outlet. But it has a 14 French pump motor as well. It was a big procedure. Why? Because not only we had to do the CT of the groin, will it be fit enough? Then you have to also involve the interventionist cardiologist and doing the whole procedure in the PPE for 5 to 6 hours, not easy, definitely. So then what was done is after general anesthesia induction, monitoring was done with, of course, arterial line, central venous line, and the urinary catheter. Cerebral oximetry was done to ensure that the pump is going to ensure good amount of oxygen even to the brain. So this is what was the ultrasound guided vascular access for the veins and the artery in the groin. So the picture may look messy over here. So this is a 14 French impella sheath. Then the next one is the 7 French coronary sinus catheter. And then the 11 French Cardo sound. Cardo sound is a great ICE intracardiac echo with which we can visualize the cardiac structures. I'm going to show some pictures as well. And then finally the Agilis sheath to manipulate the ablation catheter. With the Cardo sound, the mapping was done. And this videos will be able to see the placement of impella. Okay. So once after the impella placement was done, we could make sure that there is good blood flow and mean arterial pressure of the patient was better. The MAP was more than 65 millimeters of mercury, and cerebral oximetry was more than 55%. And then, so this is the another beautiful thing. So can you notice like how many during the procedure we had to focus upon? So for example, whenever the VT was happening, the blood pressure used to really drop. However, once we switch on the impella device, the blood pressure you will notice goes up to 111/69. And then of course we could go map the system and even the cerebral oximetry. So even though VT was continuously happening, we were able to monitor, we were able to perfuse his brain as well. We were able to ablate it successfully. And now at the end of the procedure, we were able to put a MANTA device for the closure of the axis. And after 5 months of follow-up, the patient remains to be stable. There's no VT and ejection fraction has improved to nearly 30%. And this is the wonderful team. And I must say, it's a proud moment. Dr. Shajil Shalid, who hails from Kerala in India, Dr. Bilal Patel, again, he's from Gujarat as well. These are the leaders, and including the Dr. Abuzgia. These are the leaders who had made a difference to this patient's life and also the quality of, I would say, the improvement in the overall quality of the life as well. So what I mean to say is ablation is there for patients with role for ablation of such ventricular tachycardias, and especially in idiopathic VTs like the right ventricular outflow tract VTs or fascicular VTs as well. One can get a success rate of 80 to 90% as well. So antiarrhythmic drugs, they are good options, but they can have some side effects as well. And the success rate is not always so convincing. So a lot of times it can be a bit more challenging if someone has had history of myocardial infarction. As I had said, it is due to the ischemic VT, which tends to happen in such kind of patients. And there are newer tools and technologies, which I gave you an example, which is available. The awareness needs to be there, a little bit of experience needs to be there, and definitely a good amount of success rate can be given to the patients as well. So similarly in bundle branch reentry VT as well, if we go and ablate one of the bundle branch, we can give a success rate of around 80 to 90% in fact. With HOCM, the unique thing is we can always try with beta blockers, verapamil or amiodarone, but long-term prophylactic pharmacological therapy is not recommended, especially in the high-risk population. So ICD is pretty good, pretty nice. However, as I had said, septal ablation can have a good role to decrease the outflow gradient. Similarly, for the idiopathic VT, as I already said, we can really expect a very, very good success rate in 80 to 90% of success rate as well. So I already gave you some of the examples about the vascular VT. I think everyone is knowing that this is the one which is called as the Bell-Hansen ventricular tachycardia. They are pretty sensitive to verapamil. Most of the times we come across those patients in young adult patient. I can't forget there was a patient when I was in Paris. The patient had come actually to the Paris hospital with this, but of course no one knew it, so they thought okay, it is a VT. One of my colleague even did an angiogram. So angiogram was done again in the evening. By the time I could flew in from Delhi, so the patient was again having VT. So by the time I saw the ECG, I was like, okay, this is vascular VT. Why the angiogram was done? 21-year-old guy, but things happen. So later on, we were able to convince him, and we could take him to the ablation. And later on, he's doing really well. Now, I would say he's almost more than 4 years old and pretty doing good. So the other thing, what happens is there are a lot of different risk factors as well. The aging, we already said it about the structural heart diseases and the ischemia as well. So if we try to take care of those predisposing risk factors, we can again assure a very good success rate for these patients as well. Catecholaminergic polymorphic VT, most of the times beta blockers is quite a lot helpful, and calcium channel blockers, they may not be so good in fact, although there are some early good positive reports from the flecainide. One thing I really wanted to clarify to all the eminent members who are here, ICD implantation is not a treatment for VT. It's not a treatment. And ask from those people who all have received those shocks for the ICD, it's very, very painful. It's really painful. So antiarrhythmic drugs are pretty good. There are pretty good options are there. However, problems are there as well. Similarly, in the long QT syndrome as well, we all have to be careful about the trigger factors and also the medications, which tend to prolong the QT interval. Risk stratification schemes should be based on the degree of QT prolongation, genotype, and also the sex. So for example, if someone's QT is more than 500, it has a very, very high risk for the cardiac events. Similarly, if someone is having a long QT2 or long QT3, they will be having a higher risk for sudden cardiac death compared to the long QT1. So beta blockers, yes, they're always good. And for the secondary prevention, ICDs are pretty good. Now, at our center, we are also trying for the gene therapies as well, and they are proving to be pretty useful. And also for HOCM as well, there are gene therapies which are being tried, and they seem to be pretty promising, in fact. So one of the things which everyone is scared about is the sudden cardiac death. So especially in Brugada syndrome, I really remember when I was in Maastricht, we used to refer patients to Amsterdam. So for those Brugada syndrome patients, they used to do a epicardial VT ablation catheter. So this is not right now. I'm talking like a decade back, more than 10 years back, which was happening. And now it has become really with a lot of pioneering work from Nadamani, who happens to be the royal physician of the Thailand. He has done quite a lot of good work as well in that. So in Brugada syndrome, yes, observation is important. And as I said it about the medication, I had already summarized about the treatment. So one of the question is about the short QT syndrome. So about short QT syndrome, they can be very notorious. They can easily escape the attention of any of the physicians and all. However, we have to be a little bit extra careful. And what happens is we need to be a little bit extra careful about that, not just for the treatment or initiation of therapy for such patients, but also the genetic testing, especially for the first degree relatives. So to summarize, I would say we all are, I think, blessed to have a lot of good newer medications as well. However, there's also big definitive role for ablation therapies as well. And that's why I gave you one example, which might been left at a lot of other centers to die. Nothing could be done, and no one would have known about it and all. But what I mean is, with a fresh thinking, with a good effort and knowledge, I'm sure a lot of costly lives can be saved. Thank you so much.
Thank you, Dr. Narendra Kumar ji. It's a very extensive and very clear-cut concept-carrying talk, I should say. You have let us know, we have just learned so many things from this talk. Due to the positive time, I would like allow only one question to be asked.
Ji sir. Haan ji sir.
Dr. Narendra, good afternoon. I'm Dr. Narendra.
Ji sir, haan ji. Ji sir.
We had recently one case of this patient presenting with posterior fascicular VT. After DC shock, the patient ECG showed T-wave inversion in the infralateral leads. We thought it is a case of apical cardiomyopathy, hypercardiomyopathy, but echo was completely normal. So, and after a week, ECG came to normal. So we diagnosed that it is due to cardiac memory. So he had absolutely normal heart, presenting in the posterior fascicular VT, and the typical ECG RBB with left-handed hemiblock pattern. So this patient had been having recurrent palpitation. So what is the success rate of this ablation in this type of cases? Ablation, if radio frequency ablation. You presented one case 4 years back. It is so how do you always get success, or is there any problem?
Indeed, a very good question, sir. Thank you so much for sharing your expertise and opinion as well. So indeed, what happens is sometimes some of those patients, especially in the posterior fascicular VT, we can expect a good success rate of 80 to 90%. There can be some of the cases where it can be difficult to locate those fascicular potential as well. So that's where comes the need for, or the help for, the 3D mapping as well. Rare cases can be there, recurrences can be there. Sometimes recurrences can exceed up to like 10 to 20% as well, I must say. But 70 to 80% easily we can get good success rate for them.
Thank you. Thank you.
Thank you so much.
Thank you, sir.